And Dr. Revathi has been so patiently there all through. Thank you so much, Dr. Revathi. And I think she needs no introduction. She's the chief of the cornea and refractive surgery services from Arvind Eye Care System, Coimbatore, and a veteran cornea surgeon. And she's going to take us to a very important topic. We seem to have kept it for the last, current concepts in recurrent HSV keratitis. On to you, Dr. Revathi.
Thank you, Dr. Chitra. And I was learning throughout the session, so no problem for me. I'm ready to wait. And I hope my slides are seen. Just to add a point to the previous talk, in such cases of scarring, I used to try the hydrodissection. I often talk about this, but I don't know, no takers for this somehow. Okay, moving on to my topic. Can you see my slides?
Yes.
Yeah. This is about recurrent HSV, which is the very common type of hepatic ocular disease. About 95% of it is only recurrent. And about 25% of the patients will get it in the first 2 years after the primary, and 63% in 20 years. If the primary lesion is a blepharokeratoconjunctivitis, then the chances for recurrence doubles. And in 12% of cases, it can be bilateral, especially even in children. And if the individual is atopic or immunocompromised by some reason, then the chances are really high. And the epithelial lesion, usually infective or neurotrophic. The stromal, usually the pathology is immune-mediated. Endotheliitis, iridocyclitis, both combined immune and infective pathology. The epithelial lesions, everybody knows dendro or dendrogeographic lesions, which will be appreciated well with the staining, double staining. And this should be differentiated from healing epithelial lesion, epithelial defect or effusion line, or an acanthamoeba perineuritis or a feathery fungal ledges. And the mainstay treatment here is topical, not oral, topical ganciclovir or acyclovir ointment in our part of the world where we don't have trifluridine. And both these drugs, they penetrate very well, but topical, they are more topical medications are good enough for surface lesions like epithelial lesions. Usually acyclovir or ganciclovir 5 times a day the first week. Usually we will start seeing some healing process. Then around the second week, we can reduce to 3 times and continue it at least for 21 days along with supportive therapy. And if it is not healing within a month, then we have to suspect the compliance or the drug toxicity and the trophic component. Very rarely even resistance can be a part of it. And what the first lesion here, what you see is the footprint where the lesion healed, only the subepithelial case. This is not an active lesion. We need not continue antiviral for this lesion. And metaherpetic or neurotrophic is a well-known problem in epithelial lesion, which has to be recognized. And because here we have to reduce or stop the antiviral and give low-dose antibiotic steroid to address the inflammation and to address the damaged basement membrane, and we can use amniotic membrane and also as a biological contact lens. And torsorrhaphy is the mainstay treatment here. The stromal part, interstitial keratitis is the most common, where the stroma will appear cloudy with keratic precipitates. Often this will result in scar, thinning, and vascularization. So it has to be addressed aggressively, and it has to be differentiated from acanthamoeba keratitis, and of late even microsporidial keratitis we have to rule out. And not only that, these two conditions can be coexisting in viral keratitis. That is more tricky many times. The treatment for stromal, being an immune-mediated lesion, basically steroid. And the main thing what we have to learn in interstitial type, this has to be tapered very, very slowly, as Dr. Radhika pointed out in severe VKC here. It should be, the frequency should be reduced 50% based on the response, but the duration has to be prolonged double. And as we do in uveitis, and very slowly we have to taper, and sometimes we may have to maintain them for a long time in very low dose, weekly once, like that. And whenever we use steroid, even in stromal lesions, we have to add prophylactic antiviral to prevent recurrence, especially epithelial recurrence, and the dose will be drop for drop. And this has to be continued for initial time when we use the steroid higher dose, and later on we can stop antiviral and continue low dose steroid maintenance. Endotheliitis, on the other hand, the stromal edema will be there, but the cloudiness will not be there. It can be just disciform or sectoral, or it can be diffuse, and sometimes may be severe enough to cause hypopyon and all. And here we have to, the mainstay here also steroid, but along with that, sometimes we'll give oral antiviral. And here we can taper steroid and stop faster than in stromal IK type. The necrotizing type is the most confusing one, because here it is a cytotoxic reaction which will present as necrosis. So it can be easily mistaken for a microbial keratitis, other of suppurative origin. And the recognition should be fast because it can perforate very fast. And the herpetic eye disease study, though it is quite outdated now, very long, done long back, still some of its recommendations are being followed, especially on antiviral prophylaxis, oral antiviral prophylaxis in case of recurrent. When we call recurrent, it is 2 or more episodes within a year. In such cases, we can go for oral acyclovir or valcyclovir, which is a prodrug with better bioavailability. So the dosage can be just once a day and equally effective. And but when we come across, when we plan to intervene the resulting scar to give optical keratoplasty, to do an optical keratoplasty, or when we plan for any surgical intervention, intraocular surgical intervention like IOL surgery, we have to think in mind, we have to plan for topical or oral antiviral coverage in these patients. So planning keratoplasty, the lesion should be quiescent, ideally at least for 2 years, and antiviral coverage should be started well ahead, at least 2 weeks before the surgery. And usually I prefer valcyclovir, 500 milligram. In the initial period till I give higher steroid, I used to go for a BID dose, and later it can be a prophylactic OD dose. And vascularization has to be addressed with the diathermy or other mode of therapies. And and corneal sensation should be checked. If it is grossly affected, better to avoid surgery in these patients. So the reactivation is very common in post-keratoplasty also, which is about 33%. And it can give a bizarre picture. Whenever epithelium is not healing or recurrently breaking, or on the host side, if you look carefully, you can find out that it is the viral epithelial reactivation. And endotheliitis also can occur in these patients, which can be very difficult to differentiate between from graft rejection. Then, of course, basically the therapy is almost same. We have to give steroid in both conditions, but in endotheliitis, we have to cover it with antiviral therapy also, where sometimes we have to go for very high dose of valcyclovir, 1 gram TID, and then it has to be tapered later. And neurotrophic problem in a graft also has to be kept in mind, and it has to be addressed as the neurotrophic lesion, where it can go for melt and perforation very fast. That's why it's better to avoid any surgery in these patients with where the sensation is grossly affected. So herpetic eye disease, herpetic keratitis, can it occur from the donor cornea? Not in our country, but where the donor cornea is organ cultured, then it can pass on the disease to the recipient. And coming to the summarization, topical antiviral is enough for primary blepharokeratitis or conjunctivitis or infectious epithelial keratitis, or as a prophylaxis whenever we are using steroid for the immune stromal keratitis. Topical steroid are mainstay for the stromal keratitis, disciform and endotheliitis also. But always we have to cover it up with topical antiviral also. Inflamed neurotrophic keratopathy also sometimes may need low dose steroid. Oral steroids are very rarely needed in viral, only in very severe diffuse endotheliitis or iridocyclitis with trabeculitis, or late endotheliitis in graft. And the oral therapy only always a controversial. Actively, we have to give only in stromal necrotic or endotheliitis group, where valcyclovir 500 milligram TID or acyclovir 400 milligram 5 times a day will do. In immunosuppressed patients, it has to be given double the dose. prophylaxis, it should be given as only whenever we are planning surgical therapy, or we are going for prophylaxis, more frequent recurrent episodes are there, prophylactic therapy can be given. But acyclovir, we can also, if it is even in recurrent conditions where we can't use due to patients who underwent renal transplantation and all, sometimes we have given only topical therapy also for a longer time. And maybe this also has to be proved. Acyclovir resistance also already published, and this is more in oral therapy. That's why we have to be very careful about giving oral therapy for a long time. And a word about zoster. Here, again, a study is going on because zoster also can be recurrent and devastating problems. So whether efficacy of valacyclovir 1 gram per day for an year is being studied, whether this can be reduced. And both vaccines are not seems to be affecting the incidence of recurrence. And cytomegalovirus, just a word, this also recently recognized, commonly associated with endotheliitis. Whenever you come across unexplained corneal edema, where the endothelium otherwise is normal, or post-operatively in an uneventful corneal cataract surgery, you suddenly end up with a diffuse edema, or in case of non-resolving graft rejection, you suspect CMV endotheliitis. Ganciclovir is supposed to be the best drug here. Previously, only oral therapy was promoted, but being the cost, considering the cost, we can also use topical, because even at least in uveitis, topical ganciclovir also seems to be equally effective as oral ganciclovir. So in these conditions, we can think about using topical ganciclovir. Thank you.
Thank you. Thank you, Dr. Revathi. That was a wonderful, very crisp talk. Dr. Merle, I would want to take a question from you. You're there? Dr. Sunita? Yeah. So the question is, like, if you are going to be doing a cataract surgery in these patients, so if it's a case of recurrent herpes simplex infection, you wait for the eye to be quiet for 6 months, but would you start prophylactic oral antivirals for all these patients? And what would be the regime?
Yeah, I personally prefer to start because quite often steroids is also one of the trigger factors for recurrence of HSV epithelial. So if we are planning a surgery, personally, like if I know the patient scheduled for a surgery, I start a week prior, or at least if not started prior, at least in the perioperative, I'll give the prophylactic dosing. Dr. Revathi Madam can give her thoughts on that. I think it is better to give because quite often steroids can lead to, we've seen quite many patients have an epithelial recurrence in the post-operative period.
Yeah. When we know that the scar is due to the viral keratitis, yes, of course, it's better to start. Usually we prefer to start about 2 weeks before and continue as long as we are giving steroid in the post-operative period.
If a patient has had no recurrence at all for 1 year, would you consider refractive surgery in these patients at all? And if at all, then PRK or flap?
I won't consider refractive in these patients at all.
Madam, now with the widespread availability of valacyclovir, what are your indications, or when do you switch between valacyclovir and acyclovir, or do you prefer only valacyclovir now?
I generally prefer valacyclovir because I see even well tolerated, even with acyclovir, some of them complaining gastritis and very rarely liver enzymes going up, though it is not documented in the literature. And valacyclovir I prefer, and also the dosage is easier for the patient to follow, just once a day.
Once a day.
So many of them are once a day. Prophylactic dose is only once a day.
Yes.
I think it's been a very long session, so there's any number of questions we could ask Dr. Revathi and with Dr. Sunita here. So thank you so much.